So I think that Dr. Basnight is actually trying to get out of doing some of these duty hour talks. Last month, she was supposed to do one to psychiatry, and she talked me into it. And then after that, Dr. Kramer saw that I'd done that, so she asked me to kind of start things off today. And this is really in the context of the site visits they're going to be starting next week and the week after. We have an institutional review for the whole GME institution next week on Tuesday, and the internal medicine residency program on Wednesday. Then the following week, nephrology and hemonc, and I think everybody's going to do a wonderful job. There's been a lot of preparation going on, and so this is really to bring into the forefront the duty hour standards and how we're working with those. There have been some problems with those, but it's important to understand them as faculty members and as residents. And I hope that by the end of this talk I don't see everybody like this, although I know that it's not the most exciting topic. I hope I don't need blankets and pillows at the back. So today, really what I wanted to do is review the latest ACGME duty hour standards and some of the rationale for creating them. I know that people think that there may not be a lot of rationale, but the ACGME task force did a lot of work creating these duty hour standards. To review some of the other aspects of the duty hour standards and the common program requirements, because I think that we kind of get caught up in all of the numbers and we really forget that there's other things in there that we need to be mindful of, such as supervision and handover policies, and that we need to bring everybody up to the present standards in these two areas as well. And then we need to be mindful of the recognition of fatigue and how to mitigate fatigue in ourselves and others, because the newest standards say that as an institution, we're required to teach all of you about ways that you can deal with fatigue. So what was the ACGME thinking about whenever they put forth these new standards? And what they were really trying to ensure is patient safety and resident well-being. So throughout the whole document, you'll see a lot of words, a lot of phrases about patient safety and resident well-being. And so what their opening statement is they are seeking to improve the safety of patients in our teaching hospitals today, the safety of patients who will be under the care of today's residents in their future independent practice of medicine, and then the establishment of a humanistic learning environment where residents learn and demonstrate effacement of self-interest in favor of the needs of their patients. So again, a lot of things about resident well-being and patient safety at the same time. And if you look at the scope of the ACGME review, again, this big triangle here is the effect of resident duty hours. And they really are looking at it from three areas. From resident education, so the impact of changing duty hours on your ability to learn as residents, your well-being and your time outside of here and the balance of your life, and then the safety of our patients and direct patient care. And kind of as sidelines independently, they looked at supervision and workload. And they didn't just pull these things out of the air. They actually used a lot of literature and did some searching of the literature to find what the standard should be. Of all the articles, they took 807 articles that they reviewed, and you can see how this was broken down. 157 of them related to post-2003 duty hours. So they took all of the articles prior to 2003 and just felt that had already been reviewed enough and just have come forward since the 2003 initial duty hours. 54 workload studies, 20 night work studies and 42 shift length studies, and then 9 moonlighting and 14 supervision studies. And they really clump the moonlighting and the supervision studies together because I think that ACGME sees moonlighting as an area where supervision is not adequate, and that's why they address that in that way. There were some things that they didn't look at, and the areas that they didn't evaluate were really the sleep literature that focuses on neurocognitive outcomes, any of the literature looking at the learning environment, things that were related to curricular evaluation, and then again, all of the literature that was before the 2003 duty hour standards. So I wanted to start out and focus first on the duty hour numbers, as I call them. All of those things like the 10 hours, the 16 hours, the 10 hours between duty hours. And I think that that's where we focus a lot of our attention. It's not all of the duty hours, but again, we'll kind of go through these and talk about the rationale behind these, and then later on talk about some of the other areas. So there continues to be a maximum number of hours per week that our residents can work. And this hasn't changed a lot. We still are limited to 80 hours per week. It's still averaged over 4 weeks. It's inclusive of any in-house call activities. And probably the only significant change is that it now limits to all moonlighting must be included. Previously, it only included internal moonlighting, but now external and internal moonlighting is included in this. I think that before the hours actually came out, we were concerned that that the ACGME might lower the 80-hour limit to something less than that, but they felt that should stay intact. I think it is important to understand that what these maximum hours include, so that we can all be mindful of what residents should be including in their duty hours documentation. So it really includes all clinical and academic activities related to the residency program: patient care, administrative duties of patient care, transfer of patient care, in-house call, and any academic activity. So this afternoon, when the residents are sitting over in their afternoon session, that should be included in the duty hours. Some people ask me if a resident goes home and documents patient notes at home at night, should that be included in duty hours? And the ACGME feels very strongly that if you're engaged in patient care activities, whether it's documenting at home or here, it is towards the 80-hour duty hour limit. The things that are not included are reading time and prep time away from the duty site. So if you can go home and work on your grand rounds, your chairman's conference, or whatever at home, and that's not considered duty hours. There was some rationale behind this 80 hours. Prior to this, with the death of Libby Zion in New York, 80 hours was just kind of a number that New York kind of hinged on and didn't have a lot of data at that time, but just limited to 80 hours. Since then, there have been studies done that at least suggest this is a reasonable time limit. And this is a study that is from the ACGME bulletin in 2007, in which they did a survey of residents according to how many hours they worked per week, and looked at the areas of faculty-directed teaching, peer-directed teaching, and self-directed teaching, and found that those in the 70 to 80-hour range kind of had the best learning environment for all three of those. And this is part of the rationale that the ACGME used to say that they were going to keep the duty hours to 80 hours. In regards to moonlighting, it's still, moonlighting is still a very controversial area. The ACGME doesn't want moonlighting to interfere with our residents' ability to achieve the goals and objectives of the educational program. And so they have limited it now so that time spent by our residents in internal and external moonlighting has to be counted towards the 80-hour maximum weekly limit. And of course, PGY1 residents, because they can't get an independent license, are not permitted to moonlight. There remains a mandatory time free of duty. So residents have to be scheduled for a minimum of 1 day free of duty every week when averaged over a 4-week period. So again, it's an average. So if someone's at home call and they are on call all weekend, and they have to have another weekend free to make up for that, but they can be on call for a whole week if they're whole weekend if they're at home call. When they're at home and when you're free of duty, it means that you can't be assigned any other duties. So you can't carry a pager and answer questions. You have to be completely free during that time free of duty. I think the thing that has changed probably the most is the maximum duty period length, and it's become graduated. In the previous guidelines, we had kind of one set maximum duty period for all residents. Now the ACGME has come out very strongly to say that our younger learners with less experience may not be able to deal as well with longer duty periods and may need some extra protection by having shortened duty periods that are not overnight. And so with this, probably the thing that's impacted our residency program very significantly is the reduction in duty periods of PGY1 residents to not exceed 16 hours. And you wonder if there's any, I think that this has been the biggest question for me over the period of time is there really any rationale for this reduction in hours to only 16 hours and not having overnight call? It's probably the thing that's upset people the most. And there were numerous studies that the ACGME looked at in this regard. And this is one representative one from the New England Journal of Medicine in 2004. And what they really looked at in this study was the traditional schedule with some short periods and some long overnight periods. And that was versus an interventional schedule when everybody worked just short schedules, as you can see on the below graph. And what they were evaluating was the incidence of serious medical errors by interns. And you can see in this chart that the serious medical errors by interns in the traditional schedule with long overnight periods was 176 per 1,000 patient days versus only 91 per 1,000 patient days in the interventional schedule. And that was statistically significant with a p-value of less than 0.001. And that the non-intercepted serious medical errors was also statistically significant with 58 per 1,000 patient days in the traditional schedule and only 26 in the interventional schedule. And I think these unintercepted ones were ones that no one caught, they occurred, and were very concerning for the ACGME. You can see in that graph that the types of serious medical errors made by interns included everything from procedures, medications, diagnostic errors. And so this was really what prompted the ACGME to say that our youngest learners should be protected a bit and should not have long overnight duties to reduce the serious medical errors and to improve patient safety. And as I said, it's a graduated system now, so our upper level residents, our intermediate level residents, PGY2 and above, are not limited to 16 hours and can be scheduled for a maximum of 24 hours of continuous duty, so they can remain overnight on call. That the ACGME, though, understands that this still may be problematic for people and encourage the residents to use alertness management and strategies in the context of the patient care responsibilities. And something that perhaps people have snickered about a bit is what we call strategic napping after 16 hours of continuous duty and between the hours of 10 p.m. and 8 a.m. to be strongly suggested. So people to be aware of the fact that they are becoming fatigued and to try to get some rest and allow themselves to become more alert. You might ask, why didn't the ACGME limit upper level residents to only 16 hours after that other study? Well, they looked at several other studies of more advanced residents, And many of these were in the surgical literature, but this particular study was from CHEST 2005, and it was on a group of medical residents in the medical ICU. And they looked at trying to introduce a 14-hour shift length versus the standard overnight call. And the upper graph is the overnight call group, what they call the non-pilot group, and the other one, the short 14-hour shifts in the pilot period. And in this study, they looked at these two groups and looked at things like MICU mortality, MICU length of stay, total hospital stay, total hospital mortality, and really in this instance did not find a difference. And so felt that upper level residents could safely administer care in the setting of a 24-hour period, or that there was actually no data to say that it was felt necessary to lower that limit. So the ACGME, again, very strong on patient safety and resident education. And so while they allow people to remain on site and even beyond that 24-hour period to transition care, they have pulled back the number of hours that residents can remain on site after that 24-hour period. So previously, residents were allowed to remain beyond 6 hours beyond that 24-hour period, so for a total of 30 hours. That's now been reduced from 30 hours to 28 hours. So it's now the 24 plus 4 additional hours, so a total of 28 hours. And it's important to remember that when our residents do stay longer, that you can't give them additional clinical responsibilities. So they shouldn't be picking up new patients. They should be really mindful of transitioning the care of the patients that they're caring for and getting everything set so that patient will safely transition to another provider and not doing additional work. One other thing that we've probably had a lot of difficulty with from the standpoint of multiple core residency programs is the minimum time off between scheduled duty periods. And our PGY1 residents should have 10 hours and must have 8 hours free of duty between scheduled duty periods. And I think it's important to look at the language there that when the ACGME says must, it means absolute must. And should is one of those words where they expect it to happen most of the time, and if it doesn't happen, that there should be a good reason for it not to happen. The same holds true for intermediate level residents, although if they do stay over 24 hours, then they have to have 14 hours free of duty after a 24-hour in-house duty. They understand that as residents progress in their training, that they may have times when they need to come back into the hospital or do some exceptional duty to take care of patients, and that they are transitioning to becoming independent practitioners. And so the ACGME has said that there are instances when they understand that upper level residents should return to duty to properly care for patients with fewer than 8 hours free of duty. And that is now allowed. However, they clearly say that they want all of these instances documented and submitted to the program director. And then as a program director, Dr. Kramer is required to review and track all of these instances. So if the resident says, I came back earlier before 8 hours because my patient was very ill and needed me, that would be appropriate. If it's just because someone told me to do it, that's probably not appropriate. So where did the 8-hour rule come from, where we must have 8 hours? Well, one of the places it came from was this sleep study from 2007. And it's a survey study, the American Time Use Survey study, where they looked at sleep time in hours, and that was age adjusted. And if you look right here, in the age group 25 to 34, which is where most of our residents fall in age, the average number of hours that people slept was 8.2 hours. And so they felt that all residents should be able to get 8 hours of sleep and have 8 hours free of duty, and then should have 10 hours so that they have a couple of extra hours for other activities. There is a maximum in-house on-call frequency. And again, PGY1 residents can't take call. They can only be here 16 hours. So we're really talking about PGY2 and more senior residents. And if you are on call, you can be scheduled no more frequently than every third night when averaged over a 4-week period. And I will say that we have had some duty hour violations in which the ACGME felt that we weren't complying with that standard in certain programs. So it can still be an issue. Some of our fellowship programs do take at-home call, and so there is some specific guidelines for at-home call. Any time that's spent in the hospital by residents that take at-home call still counts towards the 80-hour maximum weekly limit. The frequency of call, again, for at-home call is not subject to the every third night limitation. So again, someone could potentially be on call for an entire weekend and then be free of duty another weekend to make up for that. So you still have to satisfy the 1 day in 7 free of duty when averaged over 4 weeks. And one question that wasn't as clear previously in the old guidelines were what happens if someone who is on at-home call returns to the hospital to do a consult. They now clearly say that residents are permitted to return to the hospital while on at-home call for a new or established patient. And each episode of this, so any time that you spend in the hospital when you return to do a consult, will count towards the 80-hour limit, but it doesn't initiate a new off-duty period. So if you get called, you come in at 8:30 at night to see a TTP patient, and you go home at 10 o'clock at night, you don't need that 8 or 10 hour break between duty periods. It doesn't reset itself at 10 o'clock that night. And you might think that we're the only ones, the ACGME is the only one that's looking at this. Actually, the day that I did the duty hours talk for the psychiatry department, I got back to the GME office and Dr. Garrison stopped me and said, I just got this email and I'll forward it to you. And what it was, the Joint Commission Sentinel event alert. And here they were looking at contributing factors to fatigue and risk to patients. And they're looking at other shift workers' schedules. And basically what they say is that shift length and work schedules have a significant effect on healthcare workers' quality and quantity of sleep, and subsequently on their job performance, as well as on the safety of patients and individual safety. And they cited a 2004 study of 393 nurses over 5,000 shifts, and showed that nurses who work shifts of 12 and a half hours or longer are 3 times more likely to make an error in patient care. And this is a multi-page report. On the second page, they also cite the ACGME duty hour standards as a rationale behind why we may need to limit other healthcare workers' shifts as well. So kind of moving on beyond the duty hours, I'd like to kind of talk a little bit about some of the other things that are in the task force report and in the common program requirements now, because I think that we get so fixated on the numbers that we forget about the other things that we need to be doing. And I know in the recent site visits that are happening, the ACGME site visitor specifically asked for supervision policies and new handover policies, and we all as faculty and program directors need to be cognizant of that and making sure that our policies meet these standards. So there are some new supervision standards. And again, a lot of these are really to deal with patient safety and resident well-being. So they want to make sure that in the clinical learning environment, each patient has an identifiable, appropriately credentialed and privileged attending physician who is responsible for that patient's care. And they want to make sure that the information is available to residents, faculty members, and patients. they want us as faculty and residents to clearly inform our patients of their role in each patient's care. So you should walk in and say, I'm the attending, I'm the resident, so that patient can know who you are. And that each program must demonstrate the appropriate level of supervision is in place for all residents who take care of patients. And then they say specifically that they understand that with graduated responsibility that there are many levels of supervision, and so go on to define the levels of supervision that are there. And they say that there are some activities that actually require the supervising attending physician be physically present in the room with the resident while that occurs. There are other aspects of patient care where the supervising physician can be a more advanced resident or fellow, and that there can be intermediate levels of supervision where you're not physically there in the room as the supervising physician, but you're available by means of a pager, your telephone, or other means. And that there's even times when supervision may include kind of a post hoc review of the resident's delivered care with feedback as the appropriateness of that. So you come in the next day and discuss the case, and that may be appropriate in some instances. So again, there's in the actual ACGME guidelines, there are now levels of supervision clearly stated. And again, this is to try to ensure the graded authority of our residents. And so they want us to use the following classification of supervision, where you clearly say direct supervision, which is when the attending physician is physically present with the resident and the patient. And then these levels of indirect supervision, so indirect supervision with direct supervision immediately available, so that the attending physician is someplace here in the hospital and able to come to the bedside if called, or direct supervision available again by a pager or a telephone. You're at home and the resident can call you from the ED and talk the case over. And then what they call oversight, and this is where the supervising physician is available to provide review of procedures or encounters with feedback after that care is delivered. So somebody gets admitted during the middle of the night, the next morning you come in on rounds and review things and decide what could have been done differently or what was done appropriately. And again, I think that what the ACGME wants to see is this nice linear progressive responsibility. And so on the one side we see that supervision is going from very high to very low, authority going from very low to very high on the bottom axis, and that as you progress along as a resident, you should go through your medical school, internship, residency, fellowship, and finally on to attending physician in a nice linear fashion where you slowly pick up responsibility and that you require less supervision as time goes on, and then eventually are allowed to supervise on your own. So the handover policy is another area that is an important aspect that we've been working on in the GME office. We have developed an education subcommittee just to work on the handover standards and how to go about that for all of our different programs. And what the ACGME wants to see again is patient safety foremost. So they really want us all of the programs to design clinical assignments to minimize the number of transitions in patient care. So they don't want the pediatrics residents changing over every 3 hours on that patient. They want the fewest number of transitions to occur to allow for the safest patient care. And And they actually hold both the sponsoring institution, us in the GME office, and the programs responsible to ensure and monitor effective, structured handover processes to facilitate the continuity of care and patient safety. And I think that is obviously difficult as an institution because the needs of transition of care in internal medicine are much different than perhaps the needs for surgery or psychiatry. So we've been trying to develop things such as the minimum requirements, that what is the core of what is required in an effective handover process. And while they don't say the word evaluate, we have to ensure that residents are competent in communicating with team members in the handover process. So to me, that means we have, as faculty, we have to observe that process, make sure that it's happening effectively, and be able to document that we observe that and that we feel that people are competent in this, in communicating with team members and in making sure that this happens. As a sponsoring institution, we have to ensure that there's an availability of schedules to inform all members of the healthcare team of who the attending physician is and residents currently responsible for the patient's care. So, if you have something at the top of your note that says, call this person in the middle of the night, these are the pager numbers that you should use. Again, we have to make sure that everybody is fully aware of what's going on. And then there's some new professionalism standards that we'll review. So again, as a program director and as an institution, we have to ensure a culture of professionalism. And again, the ACGME wants to support patient safety and personal responsibility with this. So they're really trying to put the responsibility on us as physicians to be alert and to manage our time so that we give the best care possible. So they want us to accept our personal role in the assurance of the safety and welfare of our patients entrusted to our care, to provide patient and family-centered care, so that to know that the patient should be at the middle of things and not just on the edge of their own care, to assure that we're actually fit for duty. So when we come to work, that we're here, we're alert, we're engaged, and we're ready to provide appropriate care. And they actually now say that we should manage our time before, during, and after clinical assignments so that we can be engaged when we're here, so that you are responsible as a physician for what you do the night before and making sure that you have enough rest to make sure that you can be here and be giving appropriate care. And they also want us to be responsible for each other. So the recognition of impairment, illness, fatigue, in not only ourselves, but in others. So if you see one of your colleagues and they're seemingly impaired, you should be mindful of that. So again, the ACGME really is very focused on safe patient care and individual responsibility, the residents' well-being. And so again, they say that physicians must be fit for duty, that when off duty, we're responsible for managing our time to enable us to report the next day for our scheduled duty, be well rested and alert. And there's also a statement in there about honesty, that they expect us to be honest and provide accurate reporting of all elements of our training and patient care, and specifically emphasize honesty and reporting of things like duty hours. And in the past, I've gone to many programs and talked to them, and the residents will say, well, I'm not for sure I should report my duty hours honestly because I might get the program into trouble. And I always emphasize that honesty is the best policy. If there's a problem with duty hours, it should be brought to the program director's attention, and then they can do something about it. If you never tell someone about the problem that exists, or never fill it out honestly, then the program director doesn't know. And the things that happen are then the residents get upset on the ACGME survey and fill it out honestly there, but won't honestly fill out the duty hours. And that's a much bigger problem than honestly reporting the duty hours to Dr. Kramer or one of the program directors. So I always encourage people to please be honest and please tell us if there's a problem. And if you don't feel like you can tell your program the problem, tell us as an institution. We in the GME office are always willing to listen to those concerns. The ACGME now has said that as an institution, we must tell people about methods for alertness management and fatigue mitigation. I don't think that I'm the one that's the most versed in this, but again, I can tell you what the ACGME says. You have to have a process to ensure continuity of care in case someone becomes unable to perform his or her clinical duties. So if someone comes in and is fatigued, can't do their duties, we have to have a backup plan. And you should be aware of what your program's backup plan is. And as a sponsoring institution, the GME office has to provide adequate sleep facilities. So we work in all the call rooms, the lounges, and other things, and those have been in the process, even though I don't think the internal medicine's lounge has quite gotten there yet. And we have to provide safe transportation options for residents who may become too fatigued to safely return home. And just to let you know that in the GME office, we do now have a transport system that if someone were to call our office, a program director or a resident, and say, I'm too fatigued to get home safely, we will get you home. As a program, we have to educate all faculty members and residents, again, to recognize the signs of fatigue and sleep deprivation. And I think that we've had other lectures here with Dr. Sharma and others about sleep physiology. And so we've had that education already. And then alertness management and fatigue mitigation processes. And we have to adopt those processes to try to lessen the negative impact on any patient care. So what are some of the things that the ACGME suggests as far as fatigue prevention strategies? There's some simple things like obtaining adequate sleep before presenting for duty. Sometimes that's easier said than done. That if a person has sleep-related illnesses such as insomnia or obstructive sleep apnea, they suggest that you should be treated for those. You should obtain adequate exercise and nutrition. They suggest reducing the use of alcohol and hypnotics for sleep when not on duty if avoidable. And then what they call fatigue mitigation strategies, including a 10 or 45-minute nap, which again, this lecture may have provided for some people. A 1 or 2 hour nap may be helpful, although there's some experts that would say that may result in sleep inertia instead of actually increasing efficiency. So shorter naps may be more helpful. They suggest things like caffeine when you're sleepy, but not when you're awake. If you get sleepy, you can get up and start being active, exercising during duty, sitting in a room with bright lights as opposed to some place where it's dark and more easy to fall asleep. And then for our program directors, there are ways that you can monitor the trainees and how sleepy they may become. This is one scale. It's called the Epworth Sleepiness Scale, in which you have the trainee fill out this at a certain point to see how high they score. If you score 9 or above, if you're score 3 when you're sitting in a car, stop for a few minutes in traffic, or lying down to rest in the afternoon, or after lunch without alcohol. So this can help you decide if someone is more sleepy and may need to be relieved of duty. So if you've managed to stay awake, this qualifies as faculty development. If you fell asleep, then you got a strategic nap. And I was really hoping that this would help next week for our site visit. I think that we're going to have a very successful site visit. And I wish Dr. Kramer and everyone good luck.